You are live now, sir.
So good evening, everyone. So yeah, we are ready with yet another episode of our contact lens learning course, and this time we are lucky to have such a big panel, and the discussion is going to be good. And Today's topic is basically scleral contact lens, and we have I think 28. Okay. So we have a speaker who is primarily doing cataract refractive as well as contact lens, and she's quite expert in this field. So we have requested ma'am Dr. Pallavi to take this lecture, and Dr. Maya Natarajan, she is again quite an expert in this field. So we have requested her to moderate this session. So I request Dr. Maya to introduce our speakers for today and the panelist for today, and then we'll go forward with the talk. Dr. Maya?
Yeah, thank you. Good evening, everybody. Welcome to this session. I'm very happy to introduce Dr. Pallavi. I know her personally, and we've met in some forums. So she is the Assistant Medical Director and Administrator of Shushruta Eye Hospital in Mysore. And a very short introduction about her. She finished her MBBS and MS Ophthalmology from JGMC Davandere and was awarded the gold medal for the best outgoing student. Her areas of specialization are corneal and refractive surgeries, phacoemulsification, and she has a special interest in low vision aids and contact lenses, especially scleral contact lenses, and has given multiple talks on the same. She was awarded the Best Mentor Award for Teachers of Tomorrow, COSCON in Hubli, and has also been awarded the Best Video Award at the WOS session at the AIOC Cochin 2023. She has presented papers and publications in various forums. I request Dr. Pallavi to enlighten us about the scleral lenses today. Off to you, Dr. Pallavi.
Yeah, thank you for such a lovely introduction, Dr. Maya. It's an honor to be on your platform, and good evening to one and all. Okay, I'll start my presentation.
Screen.
Are you able to see?
Yes, ma'am.
Yes, Dr. Pallavi. Yeah.
You are able to see. Very good evening to one and all. I'm Dr. Pallavi Prabhu. I'm a managing director of the Sushruta Eye Hospital. I'm basically based at Mysore. Is it audible to you?
Ma'am, audible.
Okay. Can I start?
Yeah,
See,
please.
the basic thing is the eyes, they do not see what the mind does not know. So how do we get over this? So we have a blindfold when we are talking about the contact lenses, and when we are talking about scleral contact lenses, we need to know much more information than we have for the regular RGP lenses. Okay, this is my story. How did I get into this contact lenses? See, way back, I started my practice, which was in 25 years back. And at that point of time, for the keratoconus, there was not much of management. There was not even a cross-linking. Other than the keratoplasty, we did not have anything. So when it started, I started like in 1989, I started with the gas permeable lenses, which are the known RGP lenses. And at that time, the only customization they could give was the base curve, which was available between 6 to 5.4. And I was able to fit this only with my keratoconus patient who had a mild or a moderate degree of keratoconus. But I was not able to fit them onto any severe or advanced keratoconus because they used to slip off easily. So that was our limitation. Then again, slowly the hybrid lenses came into market. These hybrid lenses were nothing but they had an RGP lens in the center and they were covered with the skirting of a soft contact lenses. And they were awesome. They were very comfortable. Again, I was able to fit them between I was able to still go up to the severe cone also and little eccentric cones, which I was not able to fit with RGP lenses. I was able to do these hybrid lenses. At that point of time, the hybrid lenses was from Synergy Eyes and I used to fit those clear cone lenses, which were available in the market. But again, there was a downslide of these lenses. They used to tear off easily. So again, the patient cost effectiveness was not very good. And again, coming to, there was no customization with these contact lenses, and I was not able to fit them onto a severe or a advanced cone. Now then slowly the scleral lenses came into the market, and yes, there are plenty of scleral lenses which are available right now in India, and we started with mini scleral and scleral. And yes, the customization that it offers is just amazing, and I fell in love with it. So this is my story of my practice, of my evolution of throughout my contact lenses. Now coming to the history of the contact lenses, you will be surprised. You will be thinking, acha, scleral lenses, they must have come new to the market. That's what madam has told. No, but the history goes way back. You all know Leonardo da Vinci. He was a very famous artist. Actually, he was the person who was anatomical artist. He used to draw the anatomical representation of the figures very accurately. He was the first person who drew a schematic eye with a head which was immersed in water. What he wanted to illustrate was there was a refractive system which comes in contact with the eye. It behaves differently. And that was the neutralization of the cornea by water. That was his concept. But nothing developed further with that. But later on, we had in the 1800s, like we have this Frederick Canton Muller and Albert Karl Muller. These were called as the Muller brothers. Again, there is a history how this all started. Dr. Theodor was there from Sweden. He had a patient who had a malignancy in the eye, upper eyelid. It was in the right upper eyelid. And he had to excise most of the eyelid. And so that the cornea was exposed. So he asked his Muller brothers to invent something to help the cornea. So the Muller brothers came out with that glass blown lenses, which were available like this. So this was the first glass blown lenses, scleral lenses, which they fitted on that patient for the protection of the cornea to prevent from the exposure keratopathy. And for that patient, it worked for 20 years. See, how did it work and how did it sit? That again is an interesting story. Now we are putting paracaine for fitting. That time it was not difficult. Paracaine was not available. So they had developed something called as the cocaine eye drops. So they used cocaine eye drops and they used to fit these lenses. Again, it was like if you see on the right hand side the picture, these lenses were clear in the center, but they had an opacity on the periphery, and they were cut and they were made to fit into the. Surprisingly, that patient was using these lenses for 20 years, and he was very happy with these lenses. So that's how the history started rolling in, but that was only for the protection part of it. Now coming again to the Adolf Fusion-Fick, he was the first person who thought like, why not let me use this contact lens to help me see better. So the idea came from Adolf Fusion-Fick. That was again in the same 1800s. So now the person Eugene Kalt in 1888, he was the first person to think about devising a contact lens for only exclusive keratoconus use. And his method was also very different. He had this, he did a cauterization for the central cornea with the silver nitrate. And also he was fond of instillating myotics, and he was into pressure dressing. So he wanted to prevent the cone from coming forward. Now, again, what he also thought is, why not replace these glasses with the same as the corneal curvature? So his concept was to help the patient to improve his visual acuity. So it was during this time in 1808 that the concept of a contact lens for keratoconus evolved. Then coming to August Muller in 1889, you see the photograph on the left side. You see that person is wearing a high myopic glasses. And yes, he used a ground glass made of contact lens on himself. He had a myopia of -14 diopters, and he started using these contact lenses, and he made lot of, his research was based on he did a dissertation for this, and he presented lot of papers. Through his papers, we are aware about that these contact lenses were used, and that's how we are much aware about the background and the history of these contact lenses. So after a brief this one, then started in 1940, we have the PMMA was introduced into the market. But unfortunately, a lot of corneal desiccation was seen with PMMA because it is, as you know, it is not an oxygen permeable material. Then in 1960, it was Donald Ezekiel who started making an oxygen permeable scleral contact lenses. Then there was a lot of evolution by the materials of it, and that's how the scleral contact lenses started becoming a little rampant after 1960. Now, what are these scleral lenses which I'm talking about? Yes, these are the lenses which have a bearing over the sclera. They fit onto the sclera. And you can see that there is a clearance at the limbus and in the corneal. Now, is it empty? No. You have to fill it with a liquid reservoir. So, what liquid reservoir are you going to use? You are going to use a non-preservative free saline. So, that is a liquid reservoir which is going to be there between your cornea and the scleral contact lenses. Coming to these are the familiar terminologies, you need to be very aware about it. Corneal, yes, you are aware about it because these are the RGP lenses. Corneoscleral, yes, if your diameter is between 12.5 to 15 millimeter, we call it a semiscleral. And one more is we have that scleral. In that also we have two parts. We have miniscleral and large scleral. Miniscleral is what we are using day to in out, which is between 15 to 18, and large scleral as anything between 18 to 25. And these scleral lenses, they have a bearing on sclera, as I had told you earlier. Now, coming to the indication, where all are we going to use those contact lenses? Yes, any sort of a distorted cornea, any sort of an OSD, or after any eye surgeries. Basically, like any distorted cornea, it could be irregular due to keratoconus or a keratoglobus or any corneal degeneration or dystrophy. In any ocular surface diseases, it's been extensively used even for a dry eye patient or a graft versus host disease, or required for a Stevens-Johnson syndrome, for any corneal epithelial defect to heal, or to prevent a corneal exposure, we can use them. And after any eye surgery, like you have a LASIK where even your cornea, there's a post-LASIK ectasia, or there has been a transplant and you have an irregular cornea, you can also regularize that. And also with a radial keratotomy or PRK, or any scarring, extensive scar is there, we can still try the contact lenses. Now, I talked to you about vision improvement. I also spoke extensively about your corneal protection. Now, what about the other three categories? Yes, cosmetic, sport, and drug delivery. Now, coming to drug delivery, where is it used? See, when you have a dry eye patient, I can use a drops also within the scleral contact lenses. So like a lubricating preservative free drops, I can add 50-50 I can add, and I can help you, the patient, to maintain the moisturizer and moisture and reduce the dry eye. Now coming to the sports, any person who is actively involved in sports has got a toric lenses which can rotate and is not able to see. We can fit them with a scleral contact lens, so that will help them to see much better. Coming to the cosmetic part of it, it has got a very beautiful use in the contact lenses. See, these are the colored contact lenses you might be seeing. They have been used at Halloween, or they have been used in movie like this, like a zombie character you want to play, or you want to play a ghost character. At that point of time, you can do this colored color view contact lenses, which you can fit into the actor size, and you can play the role. So this is also one more use which is there of the colored contact lenses. Coming to the contraindications, where we should not use this contact lenses. Yes, see, whether it is RGP lens or whether it is a scleral lens, it is the same contraindication. You cannot use for a patient who has intolerance to contact lenses, or he is developing allergy, recurrent allergy, very severe form of allergy, where a lot of inflammatory markers are thrown in. You cannot use there. And patient who have got a low endothelial cell count, there is a small, but it is a relative contraindication for a scleral contact lens wear, because it can cause a corneal hydration. Edema is very common with these cases. And patients who want to use it overnight, like they want to sleep with the scleral contact lenses, again, that is not allowed. So we cannot use these lenses there. Coming to the glaucoma part of it, yes, we can use them in the glaucoma part, only tight fitting. We should see that it is not tight fit. Again, it is a very relative contraindication. Coming to why scleral are we choosing? Why over RGP lenses? Why from the other hybrid lenses? Why are we transiting to scleral? Yes, because the comfort that the patient gets is quite unsurpassed, and it restores the vision in a very compromised cornea, where even you are not able to help the patient even with your spectacles or even with the other contact lenses. And now it creates an artificial tear layer which helps to improvise the dry eye symptoms. See, again, change is the essence of life. So changing for the patient to have a better quality of vision should be our aim, day in and day out. Now, the customization part. These clearer lenses have got an amazing exceptional optics, and we can customize it to at anything. They have something called as a CAD and a CAM system. CAD is nothing but it is the computer assisted design, which when I give the order, they're going to design it on the computer, and then it goes to the manufacturing. That is called as CAM system, computer assisted manufacturing. Now, these are the available scleral lens in the market. We have from Aculens Keracare, that is the Maxim D lenses. Boston Sight scleral lenses are called Pros lenses. From the Silverline Laboratory, we have Purecon. Those are the Mac Asphere lenses. So these are available in India. The other lenses are available abroad, like the Synergia is Bosch and Lomb. There are the Zen lenses, the Jupiter lens. They are available in Europe. True Scleral is available more in United Kingdom, and in US we have the Valley Contacts and Manicon lenses. Coming to some few words when we talk about the contact lenses, whether it is RGP or a scleral, we have to be very clear with what we are dealing with. Now, these are the DK by T. What does D stand for? It is just simple. It is the oxygen diffusion coefficient. And K, it stands for the oxygen solubility constant of a contact lens material. T stands for the lens thickness. What is the DK value? DK is nothing but it's very simple. Oxygen permeability. It is the ability of the oxygen to passively pass through the contact lens material. Now, dK by T is nothing but oxygen transmissibility. It is the ability of the oxygen to move through the thickness of the contact lens. So based on that, you have this criteria for dK by T value. If you have a low dK by T value, it should be less than 12. Moderate, it is between 12 to 25. A high dK by T value is more than 25 to 50. And a super dK by T value is between anything above 51. We also have to be familiar with the second terminology called as the wetting angle. Now, what is the wetting angle? I'll give you a very simple example. I throw a drop of water on a surface. Now, because it is a water, it will immediately spread. That immediately spread is because it has got a low contact angle and it has a good wetting zone. Now the same thing, if I put an oil which is highly viscous over a plain surface, it is going to stay as a droplet. It is not going to spread across. Now that is because it has got a high contact angle. It is more than 75 degree and it has got a poor wetting zone. So we need to understand, to have a very good comfort zone, we need to have a very low contact angle or a good wetting zone, which should be less than 30 degrees. Anything between 30 to 70 will be average, and anything above 75 will be having a high contact angle. So we have to be very clear with these concepts before you start with the fitting. Now coming to the material. What is the material that has been used for making of these contact lenses? Yes, I'll brief you again later also. But the better material what they are using is fluorosilicon acrylate. It is also called as FSA. Now it is made with the tangible HydraPEC coating and the DK value is around 125. The refractive index of this is between 1.42 to 1.46. So what is the advantage of this, having this as a material? First thing, FSA is very lighter than all the other materials when you compare. So it makes a very fitting and very easy for the patient, and it doesn't feel heavy in your eye. So that is the greatest advantage that you can get with an FSA lenses. And yes, you have an increased oxygen permeability of the cornea because of your DK is 125, and increased wettability and deposit resistance is because of the HydraPEC coating. Now coming to what are the current available materials with the DK value more than 100. Now if you buy a lens from the Bausch & Lomb like Boston lenses, that is made a brand Boston XO and XO2, it is made up with a DK value of between 100 to 141 and it's made of the material hexafovcon. Now, if you come to the Contamac US, that is manufacturing this Optimum Extra and Optimum Extreme. Now, that is between 100 to 125. The material is Rofluvcon and it has got a very low wetting angle. And when you use the another, that is Menicon, that is from the America, but it has got a highest decay value of 163. It is made up of disilflocon, and it has got a very high wetting angle of 24. Now this, if you have this decay value of 163, this Menicon Z lenses, they are used primarily in orthokeratology. These are ortho-K lenses where you are going to fit for myopia, to stop the progression of myopia. These material, disilflocon with Menicon Z, is the most used one. And for the scleral contact lenses, we use Optimum Extreme with the decay value of 125, or Boston XO2, that is with 145. We are going to use that for the scleral contact lenses. A word I want to talk about, a HydraPEG. See, this HydraPEG coating again is not available with most of the lenses. This is available with AccuCare lenses, that is Maxim 3D lenses. Boston does not have in India, but it's available abroad right now. We have to choose it. That selection has to be done. This is a polyethylene glycol polymer. Now, what it does? It is a surfactant which is added over to the anterior surface of the lens as well as to the posterior surface. So what it happens is, first thing, as I was talking, it makes the angle, that is, it has a low wetting angle, so it helps to smooth spread of the tears, and also helps to have an increased water retention and increases the lubricity, and you feel that smooth feeling of the lens. You don't feel it pricking. And also it has one more advantage, is it has got a lens fogging. It minimizes it. Coming to the insertion of the scleral contact lenses. Okay, now there are few requirements. You just can't put the scleral contact lens with your eye as you do with your RGP lenses. Here we need something called as a plunger. Now you can see in the photograph that the lady has got a blue color plunger. That is an inserter. So on that you have to place your contact lens, and you have to fill it with a preservative-free saline solution. You can also see that there is a black dot mark which is present on the scleral contact lens. Few companies, they have this black dot mark to identify which eye it is. Suppose you have Boston lenses, they have one dot that is on the right eye. If you have two dots, it is present on the left eye. Few lenses like Maxim 3 lenses, they have one dot only, that is for the right eye. No dot, or there's a red dot, it is in the left eye. So the insertion is, the technique is like this. Now you have to hold the upper lid and the lower lid, and you have to bend the face forward. It has to be very parallel to the ground, and slowly you have to bring the plunger towards the eye, towards the cornea, and fix it. You have to see that there is no air bubble inside it. Suppose you end up or seeing an air bubble which is present, you have to remove it again, and you have to reinsert the lens. Coming now to the removal of the scleral contact lens. Again, now you have a different plunger for removal. It is somewhat little thin, and it has got a hole in it. It creates a vacuum suction. You just hold the upper lid and remove it out. See, whatever is appearing in this video, it looks very simple to you. But when you sit with the patient, there are different types of patients with different types of personalities. And you have to spend a quality time in counseling them. Though it appears simple here, it might take them 3 sittings, sometimes 4 sittings for them to learn how to insert and how to remove. And yes, you have to give your quality time to the patient. It's just not going to happen over a day's time. Now, these are the applicators I told you. These are the DMV lens inserter. You can see it has got a very wide base, and a DMV lens remover plunger which has got a narrow base, and you can see the hole which creates the suction through it. Now, coming to the solutions, can I use any solution which is available in the market? No. We have special, for the cleaning part of it, or by step you can use the regular RGP lens cleaner. Like we have the GP Hydra and Boston Simplus solution. They are better for a day-to-day cleaning. And for the saline which we have to fill in the contact lens, you have to use a non-preservative free saline, which is available like this from the Silverline, which is available in India, and we are using this. We cannot use other normal saline or Ringer lactate. Those bottles you cannot use, which you use for the patients. Now, coming to the cleaning of the contact lens, you have a debris, or these are your trial kits. I have used it 2-3 times on a patient. I have a lipid deposit on that. How can I remove them? Yes, earlier we used to get some enzymatic tablet. We had to insert that enzymatic tablet, or we had one hand from Bausch and Lomb. We had some Oxycept. It was a catalytic one, and this was, and it was a hydrogen peroxide system was there. So this hydrogen peroxide system used to help us remove the coating, but unfortunately they are currently out of market because they themselves used to cause lot of debris over the contact lens, and it used to cause lot of irritation. So they have removed it, they have phased out of the market right now. Now we are getting liquid cleaners only. So this liquid cleaner, now you see there's a case there. You have to, there is an activator and there is a developer. The activator is nothing but it is a sodium hypochlorite solution. We term it as a bleaching agent. So that is the activator, and the one more is the developer is nothing but it is a potassium bromide is there. This you have to place the contact lenses inside the bowl, and you have to pour in this activator and the developer, and you have to keep it for 30 minutes. Once you keep it for 30 minutes, all the lipid layer or the deposit, mucin deposits are removed out of it, and the lens becomes clearer like this. So you can see on the upper hand, you have a diagram of an RGP lens where you see the deposits are there, which have been removed very beautifully after 20 minutes. And here you have mini scleral lenses where the deposits have been removed after 40 minutes. So it's a variable time. Averagely, you can keep at 30 minutes. And once you remove all the deposits, again, you have to clean up all the contact lenses with your saline, non-preservative free saline solution. Now, how does the trial set looks? This is how the trial set looks like. These are the lenses. You can see there are few lenses in the upper row, few lenses in the lower row. Now you have got these values also which are there. Now it starts like there is a 7.65 to 7.6.75, and you see this is nothing but these are the overall we have the parameters which we need for the fitting of the lenses, and this -2, -3, -4 are the dioptric value. This 15.9 and 16.4 which you see is nothing but the diameter, and this 4.42 and above is what, 5 up to the 5.68. These are the SAG values. So now you have the base curve which starts between 7.85 to 6.75. So you need to identify, you need to understand how I'm going to start now with the lenses. Now the first fitting guide that you have to do is like all the RGP lenses, like you're going to check the vision, visual acuity will be done. Then you have to do a proper spectacle verification. Now, other than RGP, what extra you may require is you require a horizontal visible iris diameter. You have to check it. And also, if you have a topographer, it's going to be awesome. But it is not compulsory that you need to have a topographer is not there. Even with your little bit of application knowledge, you can get away without using a topographer too. Now, the fitting examination is divided into 4 techniques. You need to have the diameter. You need to check the sag height. You need to check the landing zone and the edge fitting. I'll go through each of them. Now, suppose I have a very moderate cone, or I feel that I can start with a SAG value of around 4.73 with 15.9 base value diameter. Now, but if I want to go for a very severe cone, or then I can start it with 16.4 diameter, and my basal SAG value will start with 5.41. But if I have a lens, if I have a case like it's an advanced keratoconus, I'm going to start with the basal 18 millimeters, 19 millimeters like that. So it will depend case to case. So I have to take a judgment where to start depending on the case. These are only guidelines. Now, this is how, when you start using these contact lenses, what you have to do is you have to fill in that preservative-free solution with the fluorescence strip. So what happens is there's a lot of fluorescence, which you can see, and based on the fluorescence, we are going to evaluate the patient. After fitting the contact lenses, it is going to look like this. These are the trial lenses. This is going to look exactly like this. On your right hand side, you can see at the pupil there's a circle zone, and you can see the markings 0, 45, 90, 135, 180. So 360 degree there is a marking, and you can see small curves. Those are called the hash marks. If you come to the periphery at the limbus, you see 3 dotted lines are there. These are curvilinear lines which are present. Those are our limbal indicators. So coming to the fitting part, diameter, how do I take a diameter? Yes, you have an OB-SCAN, you can use that, or with a scale or a vernier caliper, you can take it. Now imagine my diameter of the contact lens is around 11.9 or it is 12. What I have to do is add 4 to it, to the HVID. So that is 2 millimeters extension should be there beyond the limbus. So now suppose it's 11.9, then I take up a trial of 15.9. So we have 2 trials or 3 trials are also there. So we can take it up. Now, if it is beyond 12 and suppose it's 12.5, I can start with a 16.4 millimeter lens. That is how we try to take our trial sets. And we use something called as a limbal curve indicator. I just want to brief that. See, as I talked to you, there were 3 lines which were sitting at the limbus. So once you fit this lens, you make the patient wait for around 30 minutes to 40 minutes. So the lens goes back. Then what you have to do is we have to check with the slit lamp. You have to make this patient sit at straight at around 45 degree or at this one 60 degree. You can just make a swipe and see the limbal indicators. Now, if your limbus is between A to B, that means you are on target. This diameter is damn good. Now, suppose your limbus lands between B to C. I don't have to remove the lens again and refit with another design. I just tell the company person, you can have to increase this by 0.5 millimeter. If the limbus sits beyond C, I have to tell the company person to make it 1 millimeter extra. So there the trial removing and putting is totally avoided. So it is just in one trial, you can arrive at your diameter of the lens. Coming to the second value, which is very important, is the sagittal depth. It is nothing but it's a distance between the posterior surface of the scleral contact lens to your corneal apex. And a minimum while we are fitting, we try to have a SAG value of around 300. So after settling down, it reduces to 150. This is how we have the slit lamp based evaluation we can done. The front part, what you see is the fluorescent part is the tear film. The second part that you see is the dark part, that is by the contact lens, which will have an average of 300 microns. The middle part is the fluorescent, that is your sagittal depth. That should be around 300 when you start your fitting. And that the last one that you see the shadow is the corneal thickness. So this is how the central clearance should be there. So if it's like suppose you have a clearance around 50 microns, you can increase the volt. But if it's around 300 microns, it's quite ideal. Suppose you have end up with a 600 microns, you can reduce the SAG value. So this is how to start with. The 300 microns clearance will be start with, and after 30 minutes, you'll have it will be reduced to 150 microns. So this is how you end up. So even in a slit lamp, this is how you are going to get a photograph, how you are able to see. So what is the liquid reservoir that is there present that you have to see. Coming now to the limbus part of it. See, now in the left-hand side photograph you are seeing, fluorescence is present only in the center, but in the peripheral, there is no fluorescence. So there is a bearing. What it means is that your contact lens is touching the limbus and there is no depth in that. So this is not acceptable. What you see in the right side photograph, what you see is there is a clearance. There is a fluorescence, a very good fluorescence is there. It is not restricted to limbus. Mind you, that fluorescence, this is the tip. It has to go well beyond that. It has to go 1 millimeter beyond the limbus, 1 or 2 millimeter beyond lenses. Up till the landing zone, you have to see this fluorescence. Then only that means that the SAG value is quite adequate for this patient. It is an indicator. Now coming to the landing zone alignment, landing zone should be very even on the scleral conjunctiva. And also you should see that when the patient blinks, this lens should not move. In an RGP lens, what we see is the blink pattern. You see the lens should move between 1 millimeter, 0.5 millimeter, that whether it's, we try to gauge on that. But here in a scleral contact lens, the funda is your lens should not move with the blink. And if you see, and no fluorescence should be visible at the landing zone, except at the edge. Suppose again there are two parts in the landing zone. You have an inner part and an outer part. If you see there is any fluorescence in the inner part of the landing zone, that means your this lens is flat. You can just steepen it. And if you see in the there is a fluorescence in the outer part, that means it is very steep. You can flatten it. Now coming to the edge fitting. So now you see what is the good lens placement. Now you see this lens, you can see the blood vessels are coursing underneath the lens and you don't see any congestion or anything. This is how exactly your fitting should be. Now, if you have an impingement, what does it mean? Now that lens has become tight. Now lens is sitting tight and what has happened? There is an occlusion there and there is a lot of congestion is seen in the periphery. Now this can happen all around or it can happen only at few quadrant or a few clock hours. Now imagine this impingement has happened at 3 o'clock or 5 o'clock, between 3 to 5 position. Again, I don't have to remove this lens and do a refitting. What I can tell is I can do a small customization here. I can tell the company person between 3 to 5 o'clock, there's a tight fitting. I just want you to make one step flatter or a two-step flatter between 3 to 5 o'clock. If I tell that one step flatter means they are going to make it flatter by 50 microns, a two-step flatter is it's a flatter by 100 microns. So they'll just do, there is a customization between 3 to 5 o'clock we can do. And I can tell it like this also. See, between 3 to 5 o'clock, I can mention a clock hour or I can write it down 5 o'clock, 3 o'clock. I make even reduce it to 1 clock hour also. And this is like, I can even name the 150, I can write 300 degrees also. I can mention in degrees and clock hours. So this is whether it is steep or flat in any quadrant I can mention. Basically, this is only available with Maxim 3D lenses. It's not available with Pros lenses. But now they have started that Smart Sight 360 degree. Now that is available in US where we can do a customization, but not available in India. The next problem is the compression. See, compression, what you are seeing here, you are seeing that there is an ischemia beyond the lens at the bearing area and at the edge area. So now what does it mean? It means it's a tight fitting lens. So tight fitting lens, it's a steep lens. So what I can tell the company person is, okay, I don't have to remove this lens and do a refitting. Just tell the company person with these measurements, I just want you to make one step flatter or two-step flatter. So that's it. They can make a 50 micron or 100 micron based on the how much compression is there. You can take that decision based on your sclera when you see in the slit lamp. Now, so we have, they have a proper diameter selection. We have a proper sagittal depth. Now we have a proper limbal landing and a proper edge fitting. Now this is how we are ready with the contact lenses. Now once, then we have to wait for again for a period of 30 minutes. Now what I have to do is over this, I have to do a refraction. I can do an AR reading, I can take and undo a refraction, and then I have to finalize the prescription. Suppose there is now some residue is there in the spherical component, I can add it to the prescription. Now suppose if there is a cylinder which is remaining, so I can correct the cylinder by adding like up to -6 cylinders, I can correct by adding into the front surface toricity. So this also can be customized. And all this I have to give to, in a prescription format that goes to the computer assisted design. And that's how the manufacturing will be done. And of course, HydraPack coating also, it is custom built in all the Maxim 3D lenses. Now coming to these vaults. Now suppose I have a patient of, you have a pingangula or have done a trabeculectomy patient. I can do a vault. I can design a vault in this laser. What when I'm doing a vault is I have to take a photograph and send to the company person that this is how this one at the limbus between 3 o'clock or at around 4 o'clock I have this one, and or at 12 o'clock I have done a trabeculectomy. I want a notch which is created. See here at this time clock hours, and they are going to design and they are going to create it. Now, what are the disadvantages? I talked to you about all the advantages, the disadvantages. The first thing is it requires an expert to fit and guide you, and it requires a lot of time. It requires more of amount of your energy is also spent in convincing the patient. And number two is like it is availability is also limited because of the expertise. And coming to the cost factor, it is little expensive because lot of customization is being done, and also the material is expensive. And adaptation time, patient does not accept it immediately. It takes around 1 month for him to get adapted to this thing. And maintenance, patient should be very good in maintenance, or that they end up having an infection. And lot of counseling is required to tell them or guide them how the maintenance has to be done. Again, problems with the scleral lenses are same as the RGP lenses. I'm not going to go through these things, problems with the day-to-day contact lenses. What I'm going to take you is what special problems I have with the scleral contact lenses. The first problem we will have is something called as misting or fogging, which happens under these lenses. You are going to see that fine debris. You can see like mucin-like thread. These are nothing, but these are the mucin and the lipid deposits which occurs in the reservoir, liquid reservoir. So from where are they coming? How and which people are getting this? See, basically, this is mainly seen with patients who have got an inflammatory problem in the eye. Could be an allergy or an atopy, or it can happen if at some area or some contact area the lens is flat, so the air bubble escapes into, or there is a small tear and exchange is happening. So the tears which are present is getting inside the lens. So that can create this. So the basic thing is, if you get a fogging, a simple solution is ask the patient to remove the contact lenses and clean it up, put in a fresh non-preservative free solution, and again reinsert the lens. But suppose you have some tear exchange which is happening at a flatter zone, again customization can be done. You tell the company person, for this customization at maybe at 4 o'clock I have this tear exchange, I just wanted to make a little tighter on that area at zone at that clock hour, they'll do it. So customization they'll do and provide you, and they do not charge for this again. Coming to the next complication that we see is the conjunctival redness. Yes, this can be seen once the patient removes the contact lenses. One, the main thing this redness can happen is because of the toxicity, or they have not used they have used a preservative based saline solution. This can happen, or a long-term wear can also happen. Or point number three is like it is a little tighter fitter lens. So you have to first understand what is the problem here, and based on that you have to give a solution to the patient. If it's a tight lens, you can make it one step flatter. Just tell the company people, they'll provide it for you. And if you try to use a non-preservative free solution to avoid this red eye. Coming to the handling problems. Now, suppose there's a patient who has got fine tremors in the hand and is not able to fit the lens with the DMV applicator. You have a ring-based applicator. These are called as easy scleral applicators. These are also available. So also it helps, like you can take you can fixate the hand, and you can take a proper guidance, and you can put the lenses, or you can even keep the scleral lenses on the floor or on the this one table top, and you can ask the patient to bend forward and put the lenses. This also can be sorted out. Now, the fourth complication that you see is the surface deposits, and you see a non-wetting area. Yes, now this is a major nuisance which we see, and this is mainly common with females because of the makeup part. So when they use this makeup, they have a cream-based makeup or an oily-based makeup, or they're using plenty of eye makeups are there. So that surface deposits get formed over that area. Now, the simplest solution for here is to put a contact lens and then apply the eye makeup, and tell the people or the patients to avoid this creamy or very oily based makeup. And even sometimes they use this oil based soaps like Dove or Pears, that also can cause this deposits. So I ask them to avoid any sort of moisturizing soaps to be avoided. And also you have this, I told you about the deposit cleaner. You can use those cleaners to help you to remove the surface deposits. Coming to the fifth problem that you face is a corneal staining. That is very common, you see. This can happen over a period of time when the lens gets sunk into the eye. There can be small touch at that area, and this is how the corneal staining can happen. This can also happen, staining can happen because of the toxicity. If they are not using preservative-free solutions, it can be seen. Suppose it is a touch is there, all you have to do is again do a pre-fitting has to be done, and you have to increase the SAG value and try to use a preservative-free solution as much as possible to avoid the toxic effects. Coming to this conjunctival bunching, yes, this also is frequently seen, like patient when they try to put the contact lenses from below, the conjunctiva gets into the contact lenses and it overrides your limbus. And sometimes if I have a patient has conjunctivochalasis also, there's a small bunching up or heaping of the conjunctiva which you see, but it's nothing much. It is not going to cause any problem to the patient. You can just leave it. Just you have to tell them how to insert properly without pulling the conjunctiva or dragging the conjunctiva into the lens. Coming to the air bubble, again, this is very commonly seen when they are applying the contact lenses. If they have not filled the contact lens solution to the brim, it's half filled, air can get in. Again, you have to tell the patient how to fill it to the brim, and you have to sit with them and show how the contact lenses have to be inserted. Again, one more problem can happen with air bubbles, like if there is a flat fit somewhere at the landing zone, there's a flat fitting. At that time of there can be a tear exchange and a small air bubble can leak into it. Again, we have to see the fluorescence where it is fitting. We have to tighten into that area or tighten the clocker, and the air bubbles can be handled in this way. So these are all the problems, what are the cause and how we have to resolve this. So these are the guidelines for us. So finally, the tips like is we have to do a proper refraction. We need to have all the parameters ready before you start your this one. You have to choose your lens parameter. We should not rush into the sessions. We have to allow 1 hour time for the lens to settle down. Minimum is 30 minutes. Check the SAG value, use the slit lamp properly. You have to swing your slit lamp between 45 to 60 degree, check the clearance, and always ask the patient his opinion and try to show him the improvement, what is best possible. Speak positively and reassuring that you are there with him for any problems which are there, and use a proper body language and an eye contact. So this is very much required, that your positivity reflects as a personality and patient feels lot of motivation to use these contact lenses. So this is my topic for now. I have another topic about the customization. Can I change my slides, sir?
Yes, Dr. Pallavi.
Yeah, I will change my slides now.
Yes, please go ahead.
Can you see the slides, sir?
Yes, Dr. Pallavi.
Now I have
No.
another
You'll have
talk.
to reshare again, I think.
Pardon?
You have to share it again.
Yes, sir.
Yes, Dr. Pallavi, it's visible.
Now you are able to see?
Yeah.
Now, okay, now my topic here is customization. What customization can be done? This is a little more advanced than what we are talking about. Those was a scleral contact lenses, so the basics, just a basic, how do we fit and what is the guide. Now I have a patient who has got a very advanced KC. He has a PMD and is not suitable to any treatment other than keratoplasty. What next? Can he be given a scleral lens? Yes, he can be given a scleral lens, That is the customization. That is a stop. I don't say that we are overtaking keratoplasty, but it is a stopgap arrangement up till the patient decides that, okay, I want to go with the keratoplasty. You can offer this solution. So these are the customized clear lenses for all sort of corneal irregularities. And this is possible with Maxim 3D lenses. Now, these are the customization, what the KeraCare can do. So they can modify your central vault, they can give you an oblet design, they can do all the edge modification, they can have an high order aberration, they can help you to reduce it, they can do an on-point alignment, they can put you on a front surface cylinder, and of course, HydraPack coating and multifocal, all these they can do. Now, coming to the customization, the first customization is with respect to the central vault. As I told you, you have a keratoconus patient, an advanced keratoconus patient, more than 60 diopters. Chalo. So what I can do? Now this is a case with 83 diopters, very thin cornea like 267 or 283 microns. Yes, we can do a fitting for this. Now these are the customization that is possible. What I can do is I can use an 18 to 25 millimeters diameter lenses, and the sag value I can increase and I can customize this. See, I can increase the sag value of this KeraCare lenses between 600 microns to 800 microns. We can go around, say. So any advanced cone, we can fit these lenses. So that is with the help of the design. Now coming to the second modification that is possible. Now I have a keratoconus or I have a pellucid marginal degeneration, but it is not a central cone. There is an ectatic cone, or it is an inferior cone, or it is inferotemporally displaced cone, or it is inferonasal displaced cone. Now what can I do? There is another possibility. We can do something called as oblet designing. Now, what is this? Now, you see the left side contact lens. You can see that there is fluorescence everywhere, but at the inferonasal part, there is a touch. Now, how do I handle this? Yes, we can handle this. What I can do is I can increase the vault where it is touching. That is the mid periphery. I can raise the vault. I can do this with something called as oblet design, or we have something called as a reverse geometry design. So I can flatten the little bit in the center. I can increase the vault in the mid periphery. So this will accommodate that touch which was happening there, and it can raise the vault in that area so that whatever practicability was not feasible to fit the lenses, we can practically make the patient fit onto these lenses. Now coming to the edge modification, again 360-degree point custom modification is possible with these lenses. As I told you already, I made you aware by my talk in the previous this one. If it is steep, I can make it flat, or if it is flat, I can make it steep. It is, as I told you, one step flat is 50 microns, two step is 100, three step is again 150 microns, four step tak I can go up to 200 microns. I can customize, modify at any clock hour. At it may be 1 o'clock, 1 clock hour, 2 clock hour, or 3 clock hours. I can do that. That is the edge modification that is possible with the KeraCare lenses. And that notching also had told you. Now you see this notching is beyond the limbus. So these are the customization beyond the limbus. Now suppose I have a grade 2 or a grade 3 pterygium. Now it is extending inside the limbus. Can we do a modification? Yes, we can do it. This is achieved by again an AccuVault design. So now you see on the left side, my pterygium is there up to grade 2. It is coming inside the limbus, and I can create a micro vault which can be positioned inside the lens also to see that there is no bearing over the pterygium area. So that can also be designed. But while designing this, again, I have to take a photograph, and I also have to see how my trial lenses are fitting over it with fluorescein. I have to send both the video and the photograph to the this one person representative, and he is going to build a contact lens me for that design. Now coming to the HD optics clear lens, these are going to correct your aberration. So high order aberrations are also, these lenses are going to help us with that. But only the spherical aberrations can be corrected. So what they are doing here is in the central 6 millimeter zone, they are making a vault. That means they are going to add maybe a 50 microns vault is added. It's flattened there, so that any spherical high order aberration or spherical aberrations are taken care by this design. Coming to the optic zone decentration or something called as on-point alignment. Now what happens is, as I told you, there's a circle here and there's a pupil. It is not matching into the pupillary zone. You see that it is decentered. So now I have to see that the center of the contact lens fits exactly into the center of the pupil area. Now, what I can do is, these are the 3 hash marks which are present. So you can see these 3 hash marks should always be in the pupil area at the zone of 0 degree it is there. Now I can see that there is a 3 hash marks which are present at the 90 degree. But now you see there is a 4 hash mark which is present at 45 degree. So now I can tell the company person that when I'm ordering, I have to do that. There is a 4 hash marks at 45 degree. If I write this and give, now automatically the company people will see that the manufacturing is done in such a way that at 45 degree, the center of the lens is shifted above at 45 degree and brought exactly into the pupil center, so that it helps the patient to see and no sort of aberrations are happening at that point. This is one more best modification that is available. Now, one more custom modification that is available with these lenses is its front surface toric. See, this front surface toric is amazing. When we do a trial lens, we see that there is a residual astigmatism. So I can add it onto the design. I can place an order. I want a cylinder in this axis, and this will be put it on the front surface. Up to -6 diopters we can add here. Now, after adding, there's one more thing. The contact lens should sit perfectly. It cannot move. That stability is also an issue. So what Caracare has got is they have got a double slab of technology. We have heard about prism ballast even in other contact lenses. So prism ballast happens only at 6 o'clock position. It's not much. But in double slab of technology, what happens is they have added at around at 5 o'clock and 7 o'clock at 2 enter point areas, they have increased the thickness of the contact lenses by 0.2 millimeters. So what happens is there's a 200 micron thickness is there, so that the contact lens does not rotate. However you put, it is going to remain stable in that particular direction. And of course, there are markers to guide us. These markers should be present between 12 o'clock and 6 o'clock, so that it enables us to understand that these toric lenses are fitting properly. So this is how we are able to help the patients to see better. Coming to the Hydra Pack coating, I have already told that it creates an low wetting angle, and about the materials also had briefed you. Then another modification that is possible is a multifocal. This is again a newer concept. Again, like they have 2 types of modification. One is a center distance modification and second is a center near zone. Suppose you have a patient who is young and you have only around 1.5 diopters add is there, you can go for a center distance zone multifocal lenses. But if it's more or a higher add is there, you can go for a center near zone. Also, you can do a mix and match, like what we do a micro monovision or we do in our intraocular lenses when we operate. The same concept can also be used here. For the dominant eye, I can do a center distance, and for the non-dominant eye, I can give a center near zone. This also helps with that. So it's just by trial and error what the patient is comfortable. We have to do the trial and then we have to order for these lenses. But again, the problems are there. See, again, the circles which are present over the contact lens, they are of the refractive pattern. So if you use a refractive IOL, what are the problems you have? The glare, halos, the same thing the patient is going to face, the same point of complications the patient is going, and adaptation time is very high. It may take more than 1 month also. And neuroadaptation is one more factor which we have to keep in mind. So neuroadaptation takes time, maybe 6 weeks. We have to make the patient, counseling is very, very important in multifocal. It's not as simple as the other lenses. We have to sit hand in hand. We have to counsel them. We have to tell them multiple times that these are the problems that you're going to face. So we have to mentally make them ready. So this is how we process our order, which eye we are going to do, what is the base curve, finally, what is the power, what is the diameter, what is your sag value, any specific modifications you want, and if possible, try to send the corneal photographs and video of the fluorescent pattern of the scleral lenses. The company takes around 3 to 4 weeks to deliver your order. And again, these are the available lenses. I did a comparative analysis between the Boston lenses, Silverline, and the Keracare lenses. Again, as I told you, lot of flexibility is available with Keracare lenses. I am basically doing lot of Keracare lenses. I do not do Boston lens. I do not do the Silverline lens. Coming to the toric scleral part of it, it's available both with Keracare and Boston. Multifocal lens is not available with anything other, only with Keracare. Coming to the Hydrapec coating, again, it's only available with Keracare Maxim 3D lenses. Right now with Boston lens, I think it's available in US, not in India. Coming to the edge modifications, it's possible 360-degree with Keracare, but in Boston, it's only 4-quadrant modification. See, either I can modify between 3 to 6 o'clock hours, or 6 to 9, or 9 to 12, or 12 to 3. That's all the modification, not 1 clock hour. I want at 4 o'clock, or 6 o'clock, or 7 o'clock. That is not possible with Boston lens, but it's possible with Keracare. Now, coming to the limbal curve indicator has a guidance. It's not available with the other two. It's available with Keracare. And also the high definition optics. Yes, it's available with Boston lenses. It's called as E-lens. It is that is called as front surface eccentricity. That is made with a fitting on the Boston lens. And coming to the durability, yes, this is very important because these Keracare Maxim 3D lenses, they never break. They are not they're not fragile, and yes, even roughly we can handle this lenses. And my patients have been using it for so many years. They've been using one patient, and I think many patients are using up to 3, 4 to 5 years. They can use, but the company recommends it to be changed every once in 2 years or 3 years. But my patients have been using them for 5 years. Coming to the Boston lenses, they are very fragile. They break more often. Again, silver lenses, they're less fragile. They are very good, durable. Coming to the optic zone decentration, that's not available with, again, Boston and Silverline, but it's available with Keracare. And notch availability, customizing notch is available with Boston and Keracare, but it's not available with Silverline. So these are the few differences I wanted to highlight between these lenses which are available in the Indian market. Now, as I told you, there's a state of art. We have the CAD and CAM design. Now, coming to the advancements, which I tell you, they have to be done by a lathing. CNC lathings are used for all the Keracare designs, which I have told you. And they have a process of plasma treatment to see that the wetting angle is maintained low. And through this dense design, they are able to give you a best trial and also a best fit lens which is possible, and they help the patients in all sort of customization. So this is what the V-Square is doing. They offer you training on the diagnosis of keratoconus. They also give you trial assistance and dispensing at our hospital. They also give an hands-on training how to handle these lenses. They also are setting up myopia and a dry eye clinic. And these are the contact numbers of the people. Vinay and Swastik, they take care of these things. Thank you.
Dr. Pallavi, that was an excellent presentation. Extensive. You seem to have covered everything from history to indications to step-by-step method of fitting the lenses, and of course the modifications of the miniscleral lenses, the Keracare lenses. It was an excellent presentation. We can take questions now, and please type up your questions in the chat box for those who are participating. Please do that so that I can address the questions to Dr. Pallavi. In the meantime, a few things that I would like to ask is, one is like, this is for everybody in the audience, the hours of use of this lens. Generally, how long can the patient use the lens on a daily basis?
Can I speak?
Yeah,
Yeah.
please.
See, basically, like I have been fitting these lenses for so longer years. Scleral lenses, they can use comfortably anything between 6 to 8 hours, provided they don't have allergy or midday fogging and all that. If they have this midday fogging problem, no, these are the patients where they have to remove the lens and reinsert. These are the patients where we need to reduce the wearing time. Otherwise, they aram se they can do up to 8 hours a day. 8 to 10 hours. One of my patient is using even 10 hours a day. It depends
Yeah,
on the
I've had a,
fitting. It depends on
yes.
the fitting. Everything is like custom-based fitting. Fitting is the key word to a success for a successful scleral story.
Yeah, I've had a couple of patients who wear it almost 10 to 12 hours a day. And probably if it's fogging, they remove it, change the solution, and put it back on, but they can't do without it. So there are many patients who are so comfortable with scleral lenses. And my practice from RGP to Kerasofts has now almost shifted completely to mini scleral lenses for keratoconus patients. Almost give them as a first choice because of the comfort and the durability. Basically, many of my patients are using it almost like 4 years now, 4 to 5 years. Some patients have two pairs of lenses and they interchange and they use it for a longer period of time. So yes, the durability is very good.
No,
Another question is what was the steepest? You showed us a picture of almost an 80 diopter, cornea
my
that you
steepest
fitted.
has gone to a very advanced cone of 60 diopters, ma'am.
Okay.
Not more than that. 80 that they have done in the company people have done, but in my
Okay.
hands I have not done up to 80.
Do you recommend it as a first line for even patients with mild to moderate keratoconus post
See, ma'am,
cross-linking?
it's a very simple logical thing. If a patient is getting a good vision with a glass, it's a mild keratoconus patient. If glass is fitting him very well, I'm not going to advise him any contact lenses. See, first thing is to have these contact lenses also financially, it is a burden to the patient. I have to keep in
Exactly.
mind if I'm talking to a patient, what is his financial status? Now, yes, even with the glass, he's not improving and he's a student and he has to see something. He's a worker who requires his vision on day-to-day basis. Definitely, I'm going to talk to him about the scleral lens. And also, I'm going to make a small fancy. You can afford a phone which is around 50,000 rupees. You can as well afford a scleral contact lens that will help you to see the mobile phone clearly. I make a small joke. I make lot of small anecdotes, try to see that they don't feel it as a financial burden. It should be like an asset, not a liability. So that counseling has to be done, ma'am. You will get patients, ma'am. If you do a proper counseling, you can get the patients.
Any questions?
Dr. Pallavi,
Yeah, continue, please.
what is your take on in cases of secondary Sjogren's, severe dry eyes? Have you fit? Because whenever I have fit, it's always for eclectic corneal disorders and mostly keratoconus. Anybody has any, hands-on on fitting scleral
My
lenses for?
fitting for a Sjogren syndrome is limited, ma'am, because like as you said, like rightly we see if it's a Sjogren's, like immediately you will do a try to do a punctal plugs, you will try to do, or you try to cauterize the punctum, try to put them on medication and all that. But yes, but suppose this is not working on a patient, and why not give a trial? That's not a bad idea either. But not the first line. Rather, I could try it out with all my punctal plugs and all lubricants, and then I'll try to see.
That was what my take was, because I have not tried as of now. So I
But
just thought
ma'am,
anybody
I
has
did
any
try
experience.
on a patient, but she was a severe SJS patient, and somehow like she was not very comfortable, so I didn't push it onto her. See, what happens is we cannot market it also if they're uncomfortable.
No, can I just add few points here? For advanced cases of ocular surface disease, at RP center, we do give scleral lenses, and some patients are very, very happy with these lenses, especially those patients who have lid margin changes, like lid margin keratinization, because that constant rubbing, that windpiper effect, that lid viper effect, that constantly keeps on irritating the corneal surface. If you put a scleral lens, they are immediately relieved. So that group of patients, they definitely benefit of the scleral lenses. But as Dr. Pallavi highlighted, this cost is a very important factor, and that's why probably scleral lenses, the use is not that common, especially at RP center, because we are a government center, we cannot ask the patient to pay 35,000.
So in my experience, what I have seen is, so obviously it's asymmetric, the keratoconus in both eyes. Sometimes I've fit, soft toric lenses in one eye when it's, a Cooper vision, which goes beyond 2.75 also, the toricity, with one eye. And then the other one is clear lenses just to manage the finances for the patient, probably give them some, time so that if we have more mild or moderate keratoconus, probably fit with, lower order lenses like RGPs and pro scale lenses, and the other one with scleral with advanced keratoconus. That's what I've tried the combination also.
Yeah, I have tried
Discuss
soft
about
torics
that.
in very mild keratoconus patients, and they do quite well. It's surprising, but they accept, and the fit seems to be good in these patients. And the other eye, which does have a very bad cone, generally they are more accepting of a scleral lens in the other eye.
Yes, even I
Yeah,
have.
may I add? Yeah.
Yeah, I have also
Yeah.
done lot of mix and matches. I have done. One I might have given an RGP lens, or I might have also given a soft. We have this custom toric also in soft lenses. I do all that also. Customized toric up to -3 or 3.5. Fourth we have done. That also patients are good with that. Only when patients fail on this, then the scleral contact lens comes into picture.
If I may add, so I'm Dr. Aditi, I do private practice. So if the patient is affording pros from Boston, those lenses are really good for severe joint I'm sorry, SJS patients as well. And they really give very good effect. And because of the preservative that they have, they're not have the preservative. They're coating the cornea, as ma'am was telling very nicely. So, it's giving a milius and the ocular surface is much better. Even they're taking care of the scars also in many patients who have undergone, symblepharon removal or AMT and slit and all. So they are really giving good results. But again, cost is a very big factor, for which, yes, we do have to do a lot of mix and match between scleral and RGPs, and also recurrence of small panels or something like ma'am was saying. So it would be so great if we can, do the customization of that area. That's going to be a gem for those patients. So of course, there has to be a balancing between how to, counsel the patient for so much of, spending on the lens, and if something comes up. Thank you, ma'am. Excellent presentation. It was so detailed. Beautiful presentation.
Thank you so much.
So detailed, and thanks to, I'm surprised by your patience. You were making the audience understand each and everything so politely, and so, that was really awesome. Thank you so much. And if there are no questions, I think we can conclude here.
Just
Yeah,
a
no further
point
questions.
before I conclude, I could like to ask you people, what type of lenses do you fit? You're fitting Keraker lenses or you're putting Boston lenses?
My practice is fully Keraker. I have not used Boston. I've seen some patients fitted with Boston, but I have personally not fitted Boston lenses. One thing is the cost. The prohibitive thing is the cost, basically. So Keraker comparatively is definitely more affordable, and you get it on time. In at least 3 weeks to a month, you usually get it. So and customization and other things. So that again, so my practice is purely Keraker.
Okay. How
At
about
our
you,
center,
sir?
we give the patient the choices. We have
Mhm.
3 good companies. And yes, this company Keraker, we do have such lenses, but it's up to the patient, whichever they choose. After counseling, we give them. But
No,
this is a
what I
major part
wanted
of
is if
our
you are using
contact
both the
lenses. So,
lenses, which one do you find is much better?
if you
Like with
ask
your
me, it's
experience,
difficult
based on
for
now you
me.
have two things to compare, right? Because I'm more interested to know, like when you compare these two things, what are your experience, personal experiences?
personally speaking, the problem at RP center is very rare, patient comes back for follow. Once you put a contact lens, they keep on following with our optometrist. So we rarely come to know. Maybe the panelists who are directly putting it and directly dealing with patient, they can answer this question.
So any
Ma'am,
optometric?
mostly as I told you, Boston. It's a private practice, and before that, I was associated with Shankar Nethralaya. There too, we used to do cross with Boston's only. But yes, Keracare, as ma'am rightly said, the timing and the cost factor, the customization, it is actually. So it is, I think, balanced. Uh, I have seen very few patients who are complaining post Boston once because the visual improvement is really good. So that is a big factor. But again, if regarding Keracare, like in very early stages of lead margin keratinization and all, where you do know that it might progress and you might, have to shift or customize. For them, I think again, Keracare, because you can at least balance the thing. The most beautiful thing that you said is the counseling part.
That takes lot of time, but believe
Yeah.
me, I have got an excellent counselor. She takes care of all these lenses. I mean, all the, but she could have brainwashed the patient. For me, it's very easy. Just the fitting part comes to me. And yes, troubleshooting, I'm again there. For all the troubleshooting, I have handled. Or you name the complication, I've handled it.
Yeah, having a good team for, minor changes and, if you have to be answerable to the patient as well. Because once they are paying so much, they really want the best out of it. So that becomes an issue.
I think if there are no questions, we can conclude here. Thank you, Dr. Pallavi, and thank you to the panel. And I request all the panel, as I have written in the message box also, please send me your number. We are still to do another 8 courses of contact lens, and it would be quite helpful for us to take help of you people in future sessions also. And thank you, Dr. Pallavi, once again. Thank you from DOS. And I think moderator Dr. Manju, you can conclude and then let's say
Yeah.
goodbye to all of us.
Thank you,
Yes,
sir.
thank you. Thank
Good
you, Dr.
night.
Pallavi. Good night.